I'm Dr. Umbach. I've been doing bariatric surgery for now almost 15 years. It's my passion. It's what I love to do. And I've done a lot of it. I started out at USC, did a fellowship in advanced minimally invasive surgery, discovered how powerful these operations were. It's going to keep going and going and going, isn't it? And now, I've started programs and rebuilt programs and finally have a program of my own. So that's why I'm here. We are Blossom Bariatrics, and we're unique. We try to be a little different. Okay, you can see we've got a little bling going on. So we are 100% dedicated to surgery. Okay, weight loss surgery. It's not like we're doing this on the side, or we're doing this part-time, or we only cherry pick the good cases. We do it all, and we see a lot of folks. We have everything in-house that we can do to help you get started. So when you come in for your first consult, we're going to get about 80% done of what we need to get done. We're busy, we're relaxed, but we're busy. So, please be aware that we're real busy. We try to have a different atmosphere altogether, and you can see from our waiting room, we don't have the typical sliding doors. We just sign in here. We didn't do that. It's open, it's nice. We're easily accessible, and you're going to get to know folks in our office, okay? The other unique thing about us is we do revisional surgery. Revisional bariatric surgery is taking other operations from other surgeons and fixing them for whatever reason. And that's unique. Not many programs do that. But I feel if you're going to be a bariatric program, call yourself a legitimate program, you got to do the whole gamut of stuff. Okay? You got to take the easy stuff, the hard stuff. And that's how we operate. Surgery has been made unnecessarily complicated by the insurance companies. There's really only three things necessary to get to surgery. One, are you fit for surgery? Okay, and that's everybody here. Two, does it make sense to do weight loss surgery? Okay, and generally by the time you're about 50 pounds overweight, it makes sense. That's when your BMI, which is your height divided by your weight, hits 35, and that's when the insurance companies start paying. And the third thing, and the hardest one of all, is getting the insurance companies to pay for it. That, unfortunately, is the bane of my existence. I talked to a medical director today. So that's the process to get to surgery. It doesn't need to be made that complicated. It has been, unfortunately, from the insurance company side of things. Let me hire it closer. Okay. I am here because of these slides. All these medical problems are linked to obesity. And guess what? Treating the obesity treats these medical problems. So when I was doing my fellowship, I discovered that we could cure diabetes, get rid of it entirely. That just blew me away. So that's why I'm here, getting rid of diabetes. It's not my number one thing. And most people are here because they want to get healthy. That's really the real reason folks are here. They put through all the time and energy and effort to come here, is to get healthy. Unfortunately, the medical problems keep going on, and I could probably add another page to this, but I haven't, of medical problems that are helped by getting healthier. So that's why I'm here, okay? Why surgery? Why somebody standing in scrubs? The short answer is because it's the only thing that works, okay? The National Institutes of Health looked at this back in 1991, and they said, hey, surgery is the only thing that works. And the drug companies have given us the drugs, and we've all tried them, and there's some sexy names in there, Meridia and Xenical, and so forth, and we lose 20 pounds or 30 pounds, we stop the drugs because of side effects, and we gain back 25 and 37 pounds, right? So unfortunately, medical treatment for weight loss doesn't work, and probably never will because the problem is so complex. That's why a surgeon is standing in front of you. Why? Because the surgery gives you a tool to use for this operation. And when you use that tool properly, you can expect to lose about 2/3 of your extra weight. Now notice I'm not saying skinny, okay? I'm not saying you're going to get skinny, I'm not saying malnourished. Just 2/3 of your extra weight, which still means you have some extra weight to go, okay? So you're not skinny. So for example, if you're 150 pounds overweight, expect to lose about 100 on average, okay? Keep 50. Now, there are folks out there that do exceedingly well. We end up putting them up in pictures and using them for advertisements, okay? But that's not the norm. Most folks lose about 2/3 of their extra weight that they have. And the important thing is when you lose that weight, that's when the fun starts to happen because the medical problems get better, diabetes goes away, the sleep apnea goes away, the hypertension gets better, and the knees, I just talked to a gentleman actually, he's like, my knees feel great. So that's what it's all about. So, but please note, this is not the easy way out. Don't let that myth continue. It's a myth, and you'll have friends saying, you're taking the easy way out. It's not easy. You're spending time here and effort. This is not easy. Don't let that myth continue. We have expectations as well. We want patients to do well. We want everybody to do well that comes here. And we've noticed over the years that patients that do well tend to do the same things. So these are what we expect of people. Okay, to come to classes, follow our guidelines, make a few lifestyle changes, maybe some hard ones such as smoking or getting rid of soda, maybe even getting a little weight off before surgery, all right? And then after surgery, coming back to see us, coming in support groups, and then coming to see me or my PA regularly for life. These are what successful patients do. Not hard, it's not a lot, but that's why we put it out there, because we want you to be successful as well. I'm going to talk a little bit about eating, just because I want to show how simple it is, all right? We are not here to make things incredibly complicated. There are some programs where they make you measure and weigh and calculate. If I don't think I can do something, I don't ask anybody else to do it either. So trust me, it's got to be simple. First things first, protein. Protein, protein, protein. You're going to hear that over and over and over again. It's so important to put the protein in first. Next key thing is to get 3 meals a day. Okay? Believe it or not, grandma's right. 3 square meals a day makes a big difference. Okay? Slowing down at the meals makes a big difference as well. Gotta chew, slow down, savor that meal, and you'll lose weight. Protein, right? Vegetables and fruit. Getting rid of the sodas and juices, and finally we all need to exercise more. And that's really it. God, my nutritionist isn't here because she'd be pissed. 'Cause she doesn't have her talk on this. So that's really it. All right? We're going to mess up the diet a little bit. We're going to give you protein shakes. And we just give them to you around the time of surgery. Okay, so for 2 weeks before surgery, we're going to do protein shakes, and 2 weeks after. But other than that, it's regular, normal food. It's very important to me that after surgery, eventually you'll be able to eat normal food. Okay? You'll be able to go to a restaurant, have a meal, enjoy it, friends, family. Nobody needs to know you had surgery. Okay? And I think that's important to know. That's what our goal is, to be able to eat normal, healthy food. We're going to start talking about the operations a little bit. What we're doing in there is basically this concept. We're taking that big football, and that's your stomach, and we're converting it to a small egg, one way or the other. That's what all the surgeries do, more or less. Bypass, the band, the sleeve, they all kind of do the same thing in that respect. Big football to an egg. New stomach is a baby stomach and egg. Why? Because right now we're stuck filling up that football. Okay, and the brain says you can't leave that table. You're still hungry unless that football is full. Okay, that's the problem we have now. After surgery, what happens is you fill that egg. Signals go up to the brain, and 20 minutes later, the brain says, "Aha, you're done. My football is full. You can go. You're not hungry anymore." So that's how we take away the hunger with these surgeries. And that's why they're so powerful. So let's keep that in mind as we review the operations. Everything we do is laparoscopic. Most folks nowadays know what that means. That's little cuts and long chopsticks and video cameras. Okay, that's how we operate all the time nowadays. Why? It's a huge advantage to you. Way less pain, way less infection, out of the hospital quick, back to work quick. Problem is, it's a very hard surgery to do laparoscopically. So you really need to have somebody that's highly experienced in bariatric laparoscopic surgery, because it's tough stuff. First operation is the gastric bypass. That's kind of the granddaddy. Been around for 60, 80 years, and it's still around. It's a good surgery. It's done laparoscopically nowadays. What are we doing? We're taking, first of all, we put our chopsticks in, we put our camera in, and for the remainder of the case, we're working off that video camera. Okay, we don't even look at you anymore. We're playing games. And what we do in the bypass is we take that stomach, we staple it off, completely divided. We make a little stomach pouch the size of an egg. And because that pouch has to drain somewhere, we bring up a piece of small intestine to the new pouch, make a connection at the top and a connection at the bottom. So there's 2 new connections made in a gastric bypass. And what happens is the food you eat now bypasses your old stomach. Gastric bypass, that's where the term came from. And it meets up down below with all the intestinal juices in the form of a Y. So some of you may have heard the term Roux-en-Y gastric bypass. That's where these terms come from. And that's it. Okay, the old stomach stays behind. It doesn't go anywhere. It doesn't, no issues with it. That's the gastric bypass. Why do we like it? We like it because it does a lot. It does a lot for us. It takes away that hunger. It gives you good restriction. You're full. You're happy. It also does some other things. And this is really where the magic starts to happen. With the gastric bypass, we've learned over the years that it changes your hormones in your intestines. And those have profound effects on medical problems. So for example, the gastric bypass is very powerful for diabetics because of this hormone change that happens. And so 50% of my diabetic patients will leave the hospital and not necessarily take their medications again. Why? Not because of losing weight, but because of the hormone change. So the bypass is very powerful in that respect. The other thing the bypass can give you is something called dumping, where dumping is if you eat something you shouldn't, it can get you sick. Okay, it's temporary, it passes, but it's like the old slap on the wrist, only a lot harder. So dumping happens when you eat something that's loaded with sugar, chocolate sundaes, brownies, the good stuff. That's when the dumping can happen. So that's the three things that the bypass does for us really well. Okay? And the effect is amazing. Okay, we see results that are amazing. 2/3 weight loss in a year. Losing 100 pounds in a year. Getting rid of the diabetes, getting rid of the sleep apnea, getting rid of the blood pressure in a year. These are amazing results. Okay? So the bypass is very powerful. On the other hand, in every business and every facet of life, there's always a price to pay. Okay? In my world, the price is potential complications. So here's some potential complications from the gastric bypass I like to throw up there to go over, not because I like to go over them, but because I like to make sure you guys know. The first one is the mortality rate, and that's the biggie, of course. The number by itself doesn't really mean something. It's 0.2%. What does that mean? Well, first of all, if we compare it to other surgeries, it's actually safer than other surgeries. It's safer than knee surgery, safer than gallbladder surgery. So it actually turns out it's actually one of the safest big surgeries that we do. Pretty amazing. Where I see this coming into play is folks that are very sick or have had a lot of operations beforehand. Those are the folks that tend to get in trouble because their body just doesn't have the strength to fight. Okay? So for normal, healthy people, the risks aren't as high. The leak rate, we made new connections in the plumbing system. They can leak. Leak rate is low, less than 0.3%, and we check that in the operating room very thoroughly. Infection rate less than 1%. That's those little cuts, okay? And even if those little cuts get infected, it's usually not a big deal. It's basically a big zit. And a pulmonary embolism is a blood clot. This is more of a big deal. As a blood clot, it's formed in the legs and travels into the lungs. Very sudden, very severe. And the best way to prevent it is by walking after surgery. So believe it or not, people are within an hour or two after surgery up walking down the halls. Very important, okay? Reoperation is about 1.5% of the time. That's typically for bleeding issues. It can best be taken care of in the operating room. And readmissions to the hospital, usually the first couple weeks, about 3% of the time or so. These are sort of the typical complications that we worry about after a bypass. These also happen to be my complications for 909 bypasses I did years ago. I like to put them up there to show people that there's no such thing as zero complications. If you got someone telling you they've never had any complications, let me tell you, they haven't done very much. Because if you operate enough people, you're going to find something. So I think that's important for you to know. We're going to switch to the other end of the spectrum. We talked about the bypass, and then we'll swing to the other end and talk about the band. The gastric band is a device. It's done laparoscopically, so we got our same chopsticks, we got our same video camera. The only difference is this is an artificial device. So it's got to be put inside of you. And so we do that by kind of unrolling it and slipping it in. And you can see that here on the video. It slips right on in. And once it's inside, we re-lock it on itself together to form a ring. And that ring goes around the top of the stomach. So there's a small pouch the size of an egg above it. That's the gastric band. It's a beautiful little system. And it works, it's a balloon, it's adjustable, and it works by having a port. And that port is how we access the balloon. The port is underneath the skin, so nothing is sticking out. And so now we have a ring around the top of the stomach. It helps you feel full because that little stomach pouch is going to fill up. Okay, you can see that here in the video. But more importantly, we have an adjustable ring on the stomach. And we can adjust how tight or how loose that ring is. Okay, we actually do that in the clinic. It's fairly easy, it takes 5 minutes. It's a needle, so it's like a blood draw, just a quick needle into that port. You put the needle in, and then you can pump that band up or you can let it down, depending on what it needs. And that's what the gastric band is, okay? And you can see the needle going in here. It literally takes as long as this video. And you can put some fluid in, make that sucker tighter if you want to lose more weight, or if you're losing too quickly or you have nausea, back it off. So that's the gastric band, okay? Results are good, not as good as the bypass. We see maybe 50% weight loss, like 2 years, so it takes a while, okay, 2 years. But the health benefits seem to be about the same, okay? So that's the important thing, that's why we're here. The complications are totally different, all right? Because there's no cutting or sewing, there's almost no complications at the time of surgery. However, because it's an artificial device, over the years we've seen that the complications add up, okay? And so we're now at the point now with lap bands, we're 5 years out, we're removing 30 to 50% of them because of these complications, okay? So although less invasive at the time of surgery, you know, it has a pay-up time later on, you could say, you know what I mean? So that's the lap band. Now finally, in the middle between these two extremes, we have the gastric sleeve, right? This is the only operation where we're removing something. What we do in the gastric sleeve is we're cutting that football, if you will, stand it up on edge and cut it, and trimming it down. So there's a slice of football left, the size of a banana, and that's your new stomach. So that's what we do in the gastric sleeve. We actually cut the stomach away. And it does a couple things for us. First of all, it gives us great restriction, just like the others do. You know, 4 bites and you're full. But the other thing, and perhaps more important, is it also has a hormonal effects like the bypass does. So it turns out that when we get hungry, the minute you say you're going to go on a diet and you get hungry about 5 minutes later, that is actually from a hormone. It's circulating through your blood. It's called ghrelin. It looks like you know that hormone well. Yeah, you're good friends, huh? It's made in the stomach. This hormone is made in the stomach. So by taking the stomach out, we actually take out that hormone. And we take away the hunger drive that you have whenever you go on a diet. So that's why the sleeve is such a nice combination, because it has restriction like the band does, but it also has some hormone changes like the bypass does. So usually by now people say, oh yeah, Dr. Umbach, just tell me which one's best. That's up to you to decide, okay? They're good. I've had successful patients with all these operations. In fact, on this wall, got everybody, I think, represented, from bands to bypasses to sleeves. So they're good operations. They just have different benefits and different problems that you need to know about. As far as time in the operating room, it's about the same amount of time. We're less than an hour operating, and you're home the next day or home that same day, depending on insurance issues. So timeline's pretty close to similar. I wouldn't choose an operation based on one time or another. The only difference is the band. The gastric band requires adjustments to work. So that requires more visits to the doctor, which we all know is a pain in the butt because we're behind schedule and parking lot's full and it's raining and all that. So that's the only difference. The gastric band requires adjustments to work. All right, we're almost there. This is a Rube Goldberg cartoon. Anybody remember Rube Goldberg? He's an old cartoonist. And he was famous for drawing cartoons of complex machines. Only the complex machines are going to do a simple task. My pointer doesn't show up. But this simple task on this machine is to sharpen a pencil. That's all this is designed to do, sharpen a pencil. That's it. Okay? But if you don't put the basket, rabbit into the basket, you're not getting your pencil sharpened. Okay? This is how our healthcare works. I'm sorry, it's the way it works. If we don't do each step right, they will not approve your surgery. It does not matter who you are, it doesn't matter how big you are, it does not matter how sick you are. They will not approve your surgery unless you put that rabbit in the basket. Which of course has nothing to do with the surgery, but you still got to do it. So what do insurance companies like to do? First of all, they confuse you. They may tell you have to benefit for surgery, but they're not telling you the rules to get there. And the rules are critical because each rules are different from each company. And they change them about every 6 months. They make them a little harder every 6 months. So even if we had, everyone here was identical twins from Cigna or whatever, Cigna Insurance, I still couldn't guarantee that both of you could get surgery because the rules are that hard. So we got to find out the rules. You can call them up. Chances are they won't tell you everything because if you don't ask, they don't tell. If you let us do it, we will ask all the questions we know to ask and try to get all the information out of them in addition to how much it's going to cost. And then when you come in for your consult, we'll have that information for you. And that's really the best way to find out what your particular insurance requires you to do. So I had a case today, a lady denied for surgery. On the first 3 pages from her insurance company, she meets all the rules. They tacked on some on the back. New set of rules for the gastric sleeve. Guess which operation she wants. Guess which operation she can't get. The sleeve. So it all depends on those rules. So fill out the paper, let Diane get calling, we'll find that out. All right, typical requirements. First thing they like you to do is do a mandatory physician supervised medical weight loss program. Does that mean in English? It basically means come see us once a month, because that's what it means. And if it's for 3 months, you got to do it for 3 months. And if it's for 6 months, you got to do it for 6. Okay, so that's the first requirement that usually we got to get through. They'll throw in some other things in there, such as a documented history of obesity, where you got to prove that you've been heavy for 5 years or something ridiculous like that. So I've had one guy over 400 pounds, hadn't seen a doctor in 3 years. Of course the guy needs surgery. Of course he qualifies for surgery. Did he get his surgery? No, he didn't. Because he can't prove that he's been heavy or morbidly obese for the last 4 years because he hasn't seen a doctor. So, I mean, these are how tight these rules are nowadays. I'm trying not to be sensational, but it used to be 10 years ago, I could call the directors and say, look, Dr. Smith, I got Sally here. She's got bad sleep apnea, bad diabetes. Let's just get her a bypass. And you're like, hey, you're right. That's really bad. Let's get that done. I'll make it happen. No way. Not even close nowadays. So, anyways. Process to get the surgery is pretty straightforward. Come on in for a consult. We're going to get about 80% done what we can do. We're going to get insurance requirements done. We're going to get a psych eval. We're going to get labs done. You meet with me. And when you leave that consult about 2 or 3 hours later, you're going to know exactly what you need to do to get it done. Okay? And we'll do everything we can here. About the only thing we make you do is go see your regular doctor. Otherwise, we try to do it all here. And then what happens is at the end, we'll take all this paperwork and submit it for approval. It's usually about 60, 80 pages worth of papers to submit for approval. So then, of course, once we get approval, then we go to surgery. All right, so that's kind of the process. The day of surgery, my motto for the day of surgery is boring and routine. That's my motto for the day of surgery. That's what we're aiming for. So take your meds. It is general anesthetic, so you will be totally asleep. And what we're aiming for is virtually painless surgery. This is not, for most people, this is not a painful surgery. Most people are up doing stuff, okay? We have folks that come in from all over the country, and we operate on Thursday or Friday, and they usually go do something in Vegas over the weekend, the Grand Canyon or shopping or something like that. So you'll be able to do stuff. You're not going to be bedridden. Yep, walking, talking, and drinking the day of surgery, and the goal is to get you back to normal stuff as possible, as quick as possible. So that's kind of our routine for the day of surgery. Boring and routine. We have a website, please check it out. Okay, we're always tweaking it and improving it. And we also have Facebook, where we send out information as well. And a little patience, please. There will be bumps in the road. If you are using insurance to get this done, we will be undertaking the most complicated medical transaction on the face of planet Earth. Nothing is as hard as getting bariatric surgery approved. Heart attack, no problem. I get you approved for heart surgery like that. Bariatric surgery, it's tough. So please be patient. And consult's the way to go. That really starts the clock. So the goal is to get in for consultation as quickly as possible. We have 2 support groups, by the way. One support group really deals with self-image and how you can change your self-image and viewing yourself. They do a fantastic job. And the other support groups go to the more traditional support group where people meet and talk. The only difference is in our program, it's actually led by a professional therapist, not just a patient who's done well. And the professional therapist happens to have had a bypass. So she walks the talk and she talks it. So support groups, you're welcome to go through even before surgery. Go in and say, hey, what's it really like? That's about it. Okay. We got some toys to show you. Let's see. So these are some of the instruments that we use in the operating room. I like to pass these around so people can see. This is a needle driver. This guy here you use to actually sew. So you're sewing on video camera using these long chopsticks. And believe it or not, it's a skill not everybody has. So you can pass these guys around. See what they're like. And the instrument that really makes it happen though is this guy. This is, it's not a drill. It's not a drill, it's not. This is a stapler, okay? And this device will close, seal, and divide tissue on one shot. So this is really what makes the operations happen. We'd like to think it's the surgeons, but it's really this guy. Without this guy, we wouldn't be here. So you can see that guy as well. And then this is, I did some sample stomachs here, so you can see what we're working on with these stomachs. And that's the staples, because I said staples and everybody thought regular staples, right? No, these are special staples. These are made out of titanium. They're very small. It almost looks like sewing. You can see how fine that is. Look how fine that is. It's amazing. And so that's what I started to do a gastric bypass on this stomach, and I started to do a gastric sleeve on the stomach, so you can take a look and see how different they are. But mainly I want you to see the staples. The staples are made out of titanium. They don't rust. Your body just goes right over top of them. There's never been, that I know of, an allergic reaction to them. Okay, there are 2 bands for sale in the United States of America. One is a lap band, and the other one is a realized band. That's it, okay? There's no other bands for sale in the United States of America. Mexico, yes, but not here. And they're the same. They're equivalent of how they work, okay? So you can take a look at the balloons on there and the little stomach pouch. And finally, we were talking about adjusting those lap bands, making them tighter or looser. That's what we're talking about. We can put fluid in and make it tight, or we can back it off a little bit, depending on what you need. So this is for the adjustability for the bands. Okay, I think that's about it. What questions can I answer for folks?
So what's typical like scarring after the surgery?
Good question. The scarring, we have, most of the incisions are about that big, about 5 millimeters big. And then for the sleeve, there's one about a centimeter, centimeter and a half. And the band, it's a little bigger, 2 to 3 centimeters. So that's typical scarring. The little 5 millimeter ones disappear. You don't see those. And then you're left with just that one you can see.
What are the incisions for the gastric sleeve? Because I don't think you showed that.
The incisions, actually we use this, good question. The incisions are actually the same for all 3 operations.
Okay.
Pretty much the same.
So like in the same area?
Same spot, yeah. Yeah, which everything is standardized so that we use the same spot every time, same instruments. Everything is highly standardized in the operating room to increase quality. So.
What hospital do you?
Good question. I'm at North Vista Hospital, which is in North Las Vegas, which is actually, I've been around in most hospitals here and worked in most hospitals, and I gotta tell you, the care at North Vista far exceeds anywhere else I've been. I know it's not much to look on the outside, and they don't have fancy marble on the inside, but they got it where it counts, which is the people. So it's a really great hospital for bariatric surgery. North Vista also has the most experience out of any hospital for bariatric surgery. They've done probably the most bariatric surgery in the Western United States there. So nurses have that experience taking care of you because they've taken care of 10,000 patients. You know what I mean? And that makes a difference. It makes a big difference. So we go to North Vista Hospital. Good question.
So once you're admitted into the hospital, what's the typical time on it?
Well, the day of surgery is always the hurry up and wait thing. You know, you go to one room and another one, and another one, and you finally get surgery. So, and it's usually a couple-hour wait to get to surgery. Surgery takes about a half hour, and then it's usually an hour in the recovery room where you're shaking off the anesthesia, and then either going to your room for the night or going home, depending on insurance. So that's sort of the typical day. So bring a magazine or friends or something to entertain you because it's always a long day.
So are your surgeries typically done in the morning or throughout the day?
Throughout the day. We operate all day long.
And there's certain days that you don't operate?
Monday. Don't operate on Monday.
And when you cut away the stomach, you said you cut in a sleeve, you cut away half of the stomach.
Right.
Where's that half go?
That's a good question. In the gastric sleeve, we cut away actually 85% of the stomach.
So where does it go?
It comes out. The stomach comes out of a little hole that big.
Oh, so out of the incision?
Yeah, out of the incision. Think empty balloon, right? You can have a big balloon, it pops, it's a little thing. So, yeah, think empty balloon, it comes right out and we send it on its way.
So you have to sew the half that you cut open.
Well, because of the stapling, it's already sealed up. You can see the staples there.
Okay.
By the time I'm done taking all those bites, it's sealed.
So I was gonna say, so
Yeah.
as you cut, it's.
Yeah, oh yeah,
Okay,
it's
yeah.
stapling and sealing. You
Yes.
can see on that sample there.
Mhm.
That's what I mean. It's really the stapler that does the surgery for
Yeah,
us,
that's
not
good.
us. We couldn't sew that reliable. We wouldn't have this profession if we didn't have these staplers.
Right, that's good.
Yeah. They're pretty amazing. They were first actually invented in Russia. They had those in Russia, for their healthcare system in Russia. Socialized medicine, right?
Yeah.
Perfected here, and now we're going back to socialized medicine. So staples will have gone full circle.
So then you can have those staples in your stomach for the rest of your life?
Yes, the staples will stay forever. Yeah,
And
they will
there's
stay.
no need to redo them or anything?
No, you see how small, you couldn't even pick them out if you wanted to. They will stay there, the body covers up the staple line. You can't even see the staples when you go back in and reoperate because the body just covers it right on up.
Kind of like implants.
What's that?
Kind of like implants.
Yeah, it just covers it right on up. There's no reactions. There's never been an allergic reaction to the staples. They're made out of titanium. They don't rust or anything like that, so they're pretty much ideal for what they're doing.
So if you cut half of the stomach, does the stomach ever grow back to where it was?
A good question. Does the stomach grow back to, no, it cannot grow back to its normal shape. Can it stretch out a little bit? Sure, it can. We're making these sleeves, we're talking the gastric sleeve, we're making these guys the size of our thumb or finger. And even if it stretches and it doubles in size, it's still pretty small. So, good question. Plastic surgery usually comes up, that's another question. Actually, minority of patients get plastic surgery, I'd say less than 10%. So it's not automatic. And you just don't know how you're going to tone up until you tone up.
Because you do exercise.
That's the best way, whole body exercises, yep. And give it some time. The skin will lag sometimes. Particularly for the bypass, we see folks lose weight so quickly the skin catches up. The sleeves tends to be a little more on par with the skin, so we don't tend to see the same issues. But give it a couple years, and less than 10% of people go on for plastic surgery. So it's not automatic.
Now, is there kind of a plateau in your experience, be it 9 months, a year, to where you hit that height of accelerated weight loss and then you start slowing down?
Yeah, well, the weight loss actually slows down from the get-go if you graph it out. The first months you're going to lose the quickest and kind of slows down after that. So, as you go out. But, people have a surgery and sometimes 2 or 3 years later they're still losing. Slow, one every 2 months or something, but they're still losing. They just slowed way down, but they're still going down. So we try not to get caught up within how fast we're losing because it's not a race. So I won't tell you how fast you're supposed to lose or whatever. I'll just say good job, basically, because we don't want you to get caught up in the numbers. In fact, I tell people to throw the scale out. You'll know if you're losing. Your clothes feel better, you feel better. So.
Okay, how long after the surgery would I wait to get pregnant?
Okay, good question. We want to make sure our weight loss is complete before we get pregnant. Okay. Mainly because being pregnant is not a good way to lose weight. So that's the main reason, to be honest, because your weight loss will stop when you get pregnant.
Right.
So you want to wait and make sure things are stabilized. So it's usually a year or two after surgery.
Okay. What happens if you get pregnant within that time?
Your weight loss will stop.
Okay.
Now, being pregnant is not an issue. It does not make for a high-risk pregnancy. Okay, we don't have problems with pregnancies. In fact, we have the opposite problem. We have lots of whoops babies. Okay, because suddenly, as you lose the weight, you're more fertile
Yes.
and more able to conceive, and so things happen. So ideally, we want to wait until you stabilize on your weight and feel good. So that's the best way to do that. And the pregnancy is actually a healthier pregnancy, and the babies are actually healthier. So get on the way. Questions? Anything else? This is your chance to have at me here. Please.
So what, you said the next steps are making a consultation appointment?
Right, the next step, really, the way to get moving the quickest is make that appointment for the consultation.
Can we do that tonight, or?
Yes, absolutely, yeah. And I think we're only a couple weeks behind now. We were a month or so, or 6 weeks, and we caught up a little bit, so. Yeah, that's really the quickest way, because once we do that consult, that's when we sit down and look at everything in detail, make a plan, and then start the clock from there.
Is there a fee for the consultation?
Are you using insurance or? Yeah, it's part of your insurance. It's a consult visit, whatever your deductibles are.
What if you're not?
Cash pay, it's included. We include the consult, right? And yeah, it's included. Yeah, and that pay and that fee. Okay. All right, let me introduce the crew here.
Limited crew.
Limited crew. Wow.
This is a skeleton crew.
Hardcore. So Shy's in front. She's the one who manages everything, all the chaos and happens up front.
That's right.
She does a great job. Angela here is our PA, and you're going to see her where she's involved with IV fluids. We give a lot of IV fluids around the time of surgery, so she's involved with that, as well as leg veins. It happens that a lot of our patients have problems with leg veins, and so she helps with that as well. Val is here as a medical assistant, and she's on this day's Army clinic. She's going to be seeing you and getting you roomed with me, and she's also at the hospital as well. So she's a good resource for you to bug anytime. Hey, what am I supposed to be doing? Whatever, ask her.
Yep.
And then Mindy is involved with our cash pay people who have not the ability to use their insurance but are paying cash. She's your lady to answer your questions.
Yep.
So you're going to want to talk.
Okay.
Yeah, you're going to want to talk. And we have a lot more crew, but
They bailed on us.
But the point is, anybody, you can come in anytime and say, hey, what's going on? Or, hey, I'm waiting a long time, or whatever. Speak up, please, and we'll try to help you. That's really the point. All right? Well, if there's no more questions, we'll hang around privately for some more private questions if folks got them. Otherwise, what we usually do is we usually take your insurance. Well, there's Ruth. Using insurance to get surgery, right? Yeah. We want to get you squared away. Ruth is going to, we only have one insurance person.
I think we already have an appointment and everything's scheduled, yes?
Are we?
We have an appointment?
Here?
Scheduled?
Do we?
No, I don't think so.
No? Okay.
Okay, you want to get with Ruth and get something scheduled and get your insurance information and all that.
Okay.
Okay? And then the cash pays, if you stay, Mindy will talk to you for a few minutes and answer your questions directly. All right, guys, thanks for staying. We appreciate it.